Can you all, I think you all should be able to hear me now virtually. You can drop in the chat and let us know. So next we have Octavio, who's gonna lead us on a little activity. Let's hear it for OP. King of the dad jokes right here.
That performance is at noon, that's story from me. Good morning, everyone, and welcome. So yes, as Jamie mentioned, I'm one of the consultants. It's nice to see everyone, and it's also nice to see new faces, so welcome everyone. Okay, and by the way, please appreciate the humor here. The first time I shared with the team, I didn't get a laugh, but I'm sure. Just please bear with me. That's the first one, that's the first one. Okay, next slide, please.
I'm usually better at this, everybody, so.
You're doing great.
Okay, you should be.
Oh, wow. So the theme today is fair.
Okay, so thank you, Kevin. Okay, so we have 4 corners. This is 1, 2, 3, and 4. So you'll see these in the order that they are posted on the wall, meaning order it's here, right? 5 Ys is there. On that corner we have affinity diagram, and then on that corner we have the fishbone affinity diagram and the fishbone diagram. It's actually right there. So what we need to do is you will go to whichever corner you want to go, right? Once you get there, you're going to introduce yourself to the folks that are going to be there with you. You're going to share your name, title, organization, and then you're going to talk about the reasons why you chose that PDSA tool. Okay? Then we will then want one volunteer who's going to report out to the group. Right? So it's basically a summary of what everyone shared when you guys are done. Any questions? Okay, so that will be round 1 of 2. And then the second round, I'll explain what that is for now. Again, we have the PDSA tools. We have the 5 Ys here. You have the affinity diagram there, fishbone diagram, and if you use other tool, then you'll come here. Got it? So we have about 3 minutes for you guys to talk about it, summarize what everyone is sharing, and then we'll get here. We want you guys to get to share. We'll come up here for about a minute, and that will be the end of that. Cool. All right. So please break into groups, and we'll see you back in 3 minutes. Again, 5 Ys. We have the affinity diagram, fishbone, and other.
Good, how are you? You too.
And then for the folks online, you can also please write in the chat which of these 3 tools you use, or you use any, and why was it here? Again, for the people in the room, they will come up with which of these tools you selected and why. Thank you.
I'm from Legal Hospital Crisis. The guy who's
So, Andrew Wilson, prison health crisis.
You guys chose other?
Good shot. More natural.
Yes, well, we're able to connect with the needs of our clients and what we're doing as agency as far as like legal services and legal needs as far as the demographics that we serve. We're constantly connected back to their lives. Why we're doing PDSA, why we're doing and what we're doing. The work Yeah.
Thank you, Kim.
We
Yeah,
split up.
thank you,
We
Ken.
did 5 Whys and we did Fishbone. In quality program manager. But we did the 5 Whys with.
Yeah, people are drinking this
Yes,
back.
we're not, and the Fishbone we used.
And then I'll be in.
And you can always back them.
I'm in the front, because the wives or something, I don't have a picture, and then there's also, yeah, Facebook. More guns, like, seriously, by stop by.
Yeah, whatever we got. Yeah. But
Um,
also, we have, you know, 8 right. Complicated. So.
2 minutes, yeah.
And that,
General, yeah, general mental health. Care, medical, case manager, upstairs, there was illegal. Yeah.
Okay, folks, you have about a minute left. Please wrap it up. Don't forget to select a speaker for the group. And then for folks on Zoom land, we'll give you guys an opportunity to also share your tool and what you selected that tool. And you can do that by unmuting yourself if you care to. And we'll do that after folks in the room get to go first.
No, that's not.
what is the slide?
It's grabbing us. Hold on. About the county, do you have any thoughts on that? Do you want to share on the 5 Whys?
No, but what?
30 seconds left.
That and discovering in a moment. Why was that? Why we do that for why? They think it's also 25% of.
Okay. If I could please have your attention, thank you so much. Time's up. Why don't we get started? So let's start with the group to my right, the affinity diagram. Do we have a speaker from the group? Sorry, Fishbone. You're the speaker, yes.
So, I'm Sangeeta, I'm with Prism Health, and I work as the quality program manager. We had a lot of folks here who are just, attending the meeting and didn't actually work on these QI tools directly, but a lot of willingness to learn about it. And Jel and I primarily talked about using Fishbone because there were either deadlines that needed to be met or I talked about how we did the 5 Whys approach and kind of narrowed it down with the Fishbone for the Ryan White side, and then did just a Fishbone for the EHE side. So nice to meet you all today.
Thank you. Okay, let's start with the group at the end. That's the affinity diagram.
Hi, my name is Perry Rose III. I'm with Southern Black Policy and work. So you look concerned about. Am I supposed to talk?
Yeah, I'm just.
Oh, sorry. So we use the affinity diagram. So we were sharing that we were drawn to it because we could all kind of contribute to it at one time. Well, it's important in our organization. And then it also helped us when we had really broad ideas and big brainstorms. And then some were concerned about the work getting a little crazy and wanted a little bit more tailored. And we finally got to a consensus.
Thank you. And then here, since we are close.
Hello, I'm Andrew Wilson. I'm also from Prison Health, North Texas. And actually, I kind of asked Sangeeta why we did it because she's our quality program manager. But it's so the same thing she said. We started at Prison Health, North Texas with a 5 Whys more general approach. And then as we kind of identify some issues, we then use the Fishbone diagram to find sort of specific quality metrics and I think approaches. We also have legal hospice and abounding prosperity represented here, and a lot of similar things. I mean, the 5 whys for legal hospice becomes more natural, better way for them to connect with the client's needs, and they're able to kind of keep going back to the clients and how to fit their needs. And also with abounding prosperity, they're saying it's a more holistic environment. We want to be able to help with not only with their services, but also with mental health, substance misuse, also with social determinants of health. So they felt like this was the best approach to sort of address a lot of that. And even Oscar was saying with Dallas County that they appreciate it because it gives us aha moments and discovery on why we do what we do and how it all connects. So that's sort of what we're doing here.
Okay. Let's check in with our chat peeps, but I do want to point out, so, you know, one thing I love is how, as BPAN, Perry, you mentioned finding consensus. Your QI tools are meant to be done with teams and with diversity of mind and viewpoints and input, so I absolutely love that. I like, Sangeeta, how you mentioned being able to pair tools together, and actually a fishbone diagram and a 5 whys do go really well. So it's great to see folks kind of using a both and approach to really drill down on those root causes. And of course, we love our social determinant of health representation. When it comes to our chat, let's do some shout outs. So Cali Clinic also, do you mind to like share the chat a little bit? By the way, my eyes are getting old, you guys. Yeah, so Cali Clinic also mentioned using, I think, 5 whys and fishbone. Just want to show them some love. Cool. Yeah, I used the 5 whys and fishbone. So for Norma sharing for 5 whys, it really helps clarify the project. And then for them, fishbone helped them really pinpoint and identify what they wanted to concentrate on. Legacy also using a fishbone as well. And we have Cheryl and others from Che on the EHE side contributing. So OP, you want to walk us through round 2 and then we'll wrap it up.
Thank you, Jamie. Yeah, so now we'll go to round 2. Next slide, please, Kevin. Okay, so it's the same activity, right? You're gonna select the corner, you're gonna go there, and then you're gonna see this is related to the aim statement. So look around. On this side, we have linkage to care in 7 days. On that side, we have the community partnerships, the others in that end now, and then internal collaborations on that side. So we look around again and go to the corner of the was part of the aim statement. Okay, again, linkage to 7 days, community partnerships, other and internal collaboration. Yeah, about 3 minutes. And same for folks in Zoom. And thank you for your feedback on the chat. Hopefully the sound is a little better.
Oh, told I 6'5", what? I'd rather they don't fix.
What are the?
Apologies.
Like, are they, like everybody? So I would think
Unfortunately.
Align what else and then so key demographics that we're missing in our mind too, so then that way it gives us the opportunity to go connect with people in those kids with our data where we know that there are clients there for us, but they don't get limits and stuff. But this kind of network is going to get back out there and then transgender with our folks, legal services, that has been helpful for us to actually drill down specifically. If they're not performing, so gender queer, don't identify, like that kind of. So that's kind of how we went about it. We did a lot of alignment.
In this case.
Like you make a lot of the difference.
I think it's a big disparity.
When I think of waiting for it, I think. What's the age?
I think also it's how you report it, like you said.
So
So
we
that's what, what
Uh,
system
well, we
and how
can
that's
also,
actually impacted.
probably
It's
also,
different.
the benefit, the benefit services that we on the street department, we want other people to be also. We can focus on diagnosis of.
Anything from you guys are
When we, if I can't offer them how, I need to find a partner, I can't.
Well,
Provide legal service, I need to find a partner. We gotta stop. Focus on it. Take the person that knows, focus on the person as a whole person. That's why I think we need to partnership.
Or
That's coming.
going gently,
Policy.
Something that.
Oh, sorry. Here.
And I go gently with it.
Right. And for us, we have the infrastructure.
I think pretty much enough for it, so
That's right.
I think is that your?
All of this one, we have to be actually.
About 30 seconds left.
If you want to match, you can say. The community, the number from the reporters to the provider. Right, to see if that is language. We can find validity on that voice. With the partnership of the.
Okay, if we can please come back. Okay, we have the largest group go first. So you also like the linkage in 7 days. Who is the speaker?
Someone we haven't heard from you.
Yes. You'll get to eat lunch if you want. It's an incentive.
Oh, man.
Anybody? Somebody?
Dell, all right.
The problem is stopping.
Okay, so this has a little tracking device, so if we go over 30 seconds.
Okay, I'll be real quick. I understand the question to be, are we following the populations that Dallas County specified? Are we adding others? Our clinic is about 5 years old. We opened an outpatient medical clinic, LGBTQ affirming, about 5 years ago. Originally started people who could self-pay or had insurance. Eventually got Ryan White outpatient funding, which really allowed us to have about a third of our patient population now is Ryan White, 2/3 insured, LGBTQ or comfortable getting their outpatient care in the neighborhood in that environment. So we're still tracking the original populations. Most recently, as we mentioned, one quarter, gender non-conforming, non-binary was identified, and women remain, and well, youth remain as a population, and women's new category. So our clinic doesn't have a lot of women, and we don't have a lot of non-binary. So that's why I said I may not have anything too useful to contribute, but our clinic does have many gay men. That is our overall, that's our patient population of all races and incomes. So I think the selection of the populations has been organic. I think it's hit excellent points of who we should be looking at in the care continuum. And I never want to overlook gay men. That, you know, so we don't have a particular issue there, except everything we're doing in our medical care largely reflects what we're doing with our largely gay male patient population.
Okay. How about the end back there? No comments?
Yeah. We can start.
Okay, so let's go on this side.
I guess I'm here, I'll talk.
Get it out the way early.
Brandon Vance, Director of Operations for the Southern Black Policy and Advocacy Network. So over here in the community partnerships, corner, we spoke about how working in community partnerships is kind of core to what we do as an organization, SBPAN, finding non-traditional partners to bring them into the conversation as we look at ways that we can expand the message and talk to get the word out further of what we're doing. Abounding Prosperity there spoke to the need to have community partners because they specialize in what they specialize. But if they can't do housing, they need a partner that can provide housing because they're looking at the holistic whole person. And that means whatever the needs are, we find partnerships to do that. Dallas County, he talked about that they have community data. They have, that community with visits and with the numbers and things like that they can help provide to the organizations, the entities, so that they know, hey, this is what the numbers are showing. This is what the community needs based on actual data that we can share with you. And then legal hospice, I wasn't prepared to speak, and so
So we use the community partners just as an ongoing way to get out and share what we do and our services to our partnering entities. And just with the changes that we've had in our organization this year, it's just been a good way to have like a refresher and just getting back out there and letting people know what we do.
Hey, thank you all. And then from Cali Clinic, for them is a combo of Linkage in 7 days and existing and new community partnerships. Then from HSNT, our initial aim statement was to link patients to care within 7 days. Based on your data, however, they're going to add a piece for internal collaboration. Awesome. I think those are all the comments. Thank you all for participating. And if I just may say, regardless of the corner you chose in the last round, they will have an impact on the HMD care company for your side. So thank you all. Thank you all in Zoom Labs for your participation. And then I'll hand it over to Jamie.
How much is that?
Okay, everybody take your seat. I'm Angie Jones. If you don't know, I'm the Ryan White CQIP advisor. Excuse my voice. We're just gonna kind of go over our learning objectives. I'm sorry. So today we're gonna, talk more about the state we're in for our Linkage to Care QIP project using the data that we have in the PDSA cycles. We surveyed you guys, did a poll of the things y'all want to see during these sessions, and y'all talked about case studies and how important those were. So we're including some more of those today, kind of in a different way than we did last time. So we'll be talking about case studies and barriers and just our medical neighborhood that we have here, because we all are part of one big neighborhood, one big family. We all do different things, but for the same purpose. And then we'll talk about our next steps in the QIP journey, the things we're going to do between now and October, which is like 2 months. I can believe we're already in August. Okay, next slide. So our toolkit, after every webinar, we put together a toolkit of things that we use during the session or things that could be helpful for you after the session that will be loaded in glass cubes. And I think everybody has access. EHE people have their, and CQM have their glass cube side. So today's slide deck will be there. We'll have the case study scenarios that we're going to be going over today. Those will be there. We have data from EHE, medical neighborhood literature, rapid start literature, and then this session is always recorded, and that YouTube link will make it there eventually. It may take a little time for that, but it'll be in the toolkit as well. Next slide, please.
Thanks.
Yeah, and I want to give Brandon a real shout out because mentioning how Bounty Prosperity was saying, hey, what we specialize in, but we, you know, not everything is going to be in-house, right? And that'll actually tie into our medical neighborhood later. Dee, do you want to come up and we're going to share sort of the current state through what we've collected on the Ryan White side, both a little bit in terms of data as well as your PDSA cycles, and then we'll do the same for EHE. And so we'll hear from Dee and Anthony, Kevin, and myself. So far, French.
Hey, good morning, B. Well, D'Angelo Doctor for those that don't know me, but B is fine. Tomorrow we'll be discussing more with the Ryan White side about our QIP project, but we did want to share some data real quick with our regional focus populations. As Dale mentioned earlier, the three focus populations for all 9 of our subrecipients are youth aged 18 to 25, women and trans/gender nonconforming. So during Q1, which the submission was June 15th, between March and May, we were able to capture all 3 populations through all 9 subrecipient agencies. The numbers here at the top with the asterisk next to it just indicates that we have a numerator/denominator less than 5, but we were able to link 100% to care here and trans/gender nonconforming. None were linked to care in 7 days here, but there was one client that was confirmed to be engaged in care after 7 days. And then for youth, 7 of the 13 were linked to care. 13 of them were dual STI/HIV diagnosis.
Hi, everybody. Is everybody awake? This is spaghetti. My name is Kevin Davis. I'm with Dallas County's Ryan White Grant Administration under the CQM team. If you don't know what CQM means, it's clinical quality management. We're really acronym heavy here, so I'll try to explain each of those. So each of our 15 subrecipients now? 12, just kidding. 12 subrecipients utilize the PDSA QI methodology tool to gauge their QIP process throughout the year. So out of the 9 subrecipients, 8 of the 9 are in the P phase, which is what we expected. We're still waiting on one more submission from a subrecipient currently due to some changes in their QIP project. But some things I wanted to highlight are some key focuses on that the subrecipients have chosen to focus on. And so one of them is new HIV diagnosis and bacterial STI linkage to care within 7 days. Another agency wants to improve outcomes for providing affordable mental health and substance use treatment. Love that. Another agency wants to increase HIV STI testing with the area county jail. And another wants to target outreach amongst regional focus populations. So women, youth between the ages of 18 to 25, and transgender and gender nonconforming. And another agency wants to confirm engagement and care for persons new to agency support services. We noticed that in some of the submissions, one agency is in the S phase and one is in the A phase. Those are just errors. But we wanted to highlight that piece right there. And then 2 of the 3 jointly funded subs are doing separate QIP from across different programs. So thank you, and I'll pass it over to Jade.
Yeah, so we're all under this umbrella of linkage to care, but based on our different specialties, maybe mental health and substance use or legal services, or folks have STI testing and clinical care in-house, right? So we're all under the same umbrella. It's maybe just presenting or tailored a little bit more uniquely. So that's our current state with Ryan White. Let's hear EHE, y'all. Let's take it to the EHE side. Hey. So we're talking about, Kevin mentioned the QI methodology, and so we're following that Plan, Do, Study, Act, PDSA sort of cycle. So within EHE, we also have folks whose focus is looking into increasing rapid start initiation and getting that initiation on medication within 7 days or less. You know, that's part of the linkage in 7 days or less piece. We also have folks who are doing kind of more of an operational focus in order to support that health outcome. So they're really looking at their care plan protocols and recognizing in order to link people in 7 days or less, we need to go upstream as an agency and do some zhushing and some quality improvement around our care plan protocols. We also have, of course, the focus of folks who test positive for HIV for the first time and who also had a co-occurring bacterial STI, plus or minus 30 days, got some love there. We also have folks who, again, are looking at increasing the partnerships. We heard about that from SBPAN in terms to increase linkage because we need to work more as a community, get the word out, get the awareness. And then we also have representatives from EHE. We have other social media aspects that are funded. So we have folks who are looking at cost of conversion and sort of what's the most cost efficient and impactful way to utilize those EHE social media aspects to increase linkage. So I do want to give a massive shout out to all 6 EHE subs. We got the submission. This is the first time ever, you know, kind of taking a dive into following improvement and following the PDSA cycle. So thank you, thank you, thank you. And we have 3 joint funded subs who get both Ryan White dollars and EHE dollars. And out of those, 2 agencies have a project within their EHE team and then a project within their Ryan White team. And we have 1 agency who's kind of working those 2 teams together in concert. So y'all are like really kicking it. You're really accomplishing a lot. We wanted to give you some more information about where folks are. I'm going to now hand it over, I think, to Anthony to talk about data from the EHE side of the house. Let's hear it for Anthony, y'all. You really excelled.
Hello, everyone. Some of this data you might have seen before at some other presentations, so I'm going to try to move through a little quickly, but just highlighting linkage to care from an EHE perspective. This slide is just showing linkage to care within Dallas County, just the county, not the EMA or HSDA or anything like that, for 2022, which is the most recent data available. 2023 will hopefully be coming out soon from the state. Thank you. But overall, 655 people, or 73% of new diagnoses, were linked to care within 1 month of diagnosis. And then about 16% of people were linked to care within 1 year outside of that 73, but then ultimately 10% of new diagnoses were not linked to care within a year of diagnosis. This is breaking down that 73%, the 655 people, looking within 1 month of diagnosis, how quickly they were linked to care. 162 people were linked to care on the same day of diagnosis, and ultimately 424 people were linked to care within a week of diagnosis. And so that 424 people represents 47% of all new diagnoses, which is pretty good progress. This is a quick highlight of what I presented before, I think, at our last QIP session. We, as the EHE program, have been working with our sexual health clinic to improve linkage care outcomes for people who are newly diagnosed within the sexual health clinic on the first floor. So this is kind of trying to look at how long does it take for us to get people linked to care after they're diagnosed at the county here. So we started collecting data August 2023, last year, and this presentation was in March, so it was just through February of this year. We had 33 new diagnoses, and this chart is just showing the number of days to their linkage appointment from 0 to 119. And yes, there is a large variety of days that it takes to get linked to an appointment. This could be due to a multitude of reasons. It can be very hard to maintain communication with people who are newly diagnosed. So that's why we have some of these outliers here. They just required extended follow-up efforts to make sure that they actually had an appointment and attended. But there's a large cluster showing that most people were able to get linked to care within a month. So for that previous time period, about 67% of people were linked to care within 7 days. 91% of people were linked to care within 30 days. The median number of days to linkage was 9, so a little bit over that week that we were talking about, and the average was 23.6. I included both just because the data is so skewed, and just to give a sense of it. So this is updated for March through May of this year. Again, we had about 33 new diagnoses during that time, and there is still a pretty large spread, but there's only 1 count that was above 40 days. And that this patient at the end that took about 114 days to linkage was a previous positive who had fallen out of care and needed to be relinked. And so for this time period, as we've refined our processes, working with the sexual health clinic, we've increased the linkage to care rate within 7 days up to 73%. 94% of people were linked to care within 30 days. Our median has come down to 4 days to linkage. That essentially just means that 50% of this new diagnoses were linked to care in less than 4 days, and 50% were linked to care in more than 4 days. And the overall average number of days to linkage to care was 5.9. And this is including what we call a warm handoff, which is when the sexual health clinic, the doctor or nurse on staff will directly call EHE, and one of our EHE care navigators will come down and meet directly with that new patient and get them oriented with their care options and so forth. So now this is just quickly looking at our results with the sexual health clinic compared to Dallas County overall. So in green is showing the percentage of patients who are linked to care within 7 days. Sexual health clinic, as I just showed, we had 73% of our patients were linked to care within 7 days compared to 47% county overall. And yeah, that's a 26% higher rate compared to the overall county. Similar percentages for being linked to care within a week to a month. And then we ultimately did not have anyone who was not linked to care during that time period. Is this for this presentation?
Yeah.
Okay. So this is a quick snapshot looking at testing, kind of switching gears from linkage to care. And this is data coming from Evaluation Web, which is data for tests that are funded by the CDC, and this is only tests that are funded by the CDC. It does not include any tests paid for by like private or public insurance, 340B funds, patient assistance programs, or anything like that. So there is a little bit of caveat to the data, but we're just trying to show the breakdown of new diagnoses compared to previous diagnoses based on the testing data. So in red, light red and darker red are new diagnoses, and previous diagnoses of HIV are shown in blue. Roughly 33% of all new diagnoses within the county is represented in the red. And on average, 43% of positive HIV tests were new diagnoses.
Thank you, Anthony. So we're gonna have Michael come up. We're gonna move into the medical neighborhood stuff. But I think there's a moment to really pause for this. So one, really value the ability to connect with EHE and have access to this data so that we can be more data informed and data driven, especially in quality improvement. I also want to share on that last slide when he was talking about, true new positives. So you all in your QI projects might be like, yeah, we're testing people, but is it truly the first time they're receiving that HIV diagnosis? That's what that purpose of that slide is. So yes, 46%, in fact, I think it's 46% are the true news, if you will, right? So we want to continue to bring forward that information. And I also want to really celebrate the EHE CHW team and the sexual health clinic. And Anthony, you saw they have had to learn. We've got to improve the way we collect the data. We want to improve our processes for the warm handoff. And then we've been able to see them improve that linkage within 7 days from I think 40-something% to 76. So just really encouraging, and I really appreciate you all being transparent with your data. Now, let's kick it into some medical neighborhood stuff, and Kevin and Michael are gonna take us on a ride. Through the neighborhood.
Good morning, everybody.
Hey.
Oh my gosh, it's so good to be here and to share space with you guys. So we're just gonna keep on talking about what we have been talking about, community partnerships and linkage, really through the lens of a medical neighborhood. So this is something that we had presented, I think quite some time ago, as a part of maybe a couple of different TA series, but we wanted just to take a moment to remind ourselves, what is a medical neighborhood? So it builds on the concept of the medical home. Everyone's familiar with the concept of a medical home? Yeah, okay. For those of you that aren't, the idea would be that the medical home is a place where a client is mostly getting their care. But as we know, when it comes to any type of home, people leave their home to go shopping, to see their friends, to go do life things, right? So the idea would be that while there may be one side that's primarily responsible for the care of a client, there is actually this bigger structure that the client is a part of and that the care site is a part of called a medical neighborhood. And just like regular neighborhoods, medical neighborhoods are made up of multiple homes. And it's the idea where one provider cannot do it all, or doesn't want to provide, or is not able to provide all the services, or is unable to provide services in a way that all people would want to need to have. And that makes sense, right? Like, there are things that you really like as a human being about where you get one aspect of your care, but you're like, I wouldn't get my lab there. I'll go over here to this center. Well, and there's a ton of examples like that, but that's really the concept here that, medical homes, make up medical neighborhoods, and all of us are probably medical homes to a certain extent. The other thing is that we need to have these reciprocal relationships. So it's not just enough to think like, oh yeah, my client might be in care elsewhere, but we really need to have something that's meaty, something that's meaningful to tie us together. So we can think about things like payers, like, the leadership of the EMA and HSDA here at the county is really working to push us hard to think about these relationships. We have this QI project, right, as one of the main ways to help us to drive that. So we have our funding partners to help us. But the other thing that's really important that goes beyond funding, because what do we know about funding? It also has limited scope. It says you need to do just this with these people in this period of time. And as we know, as human beings, that's not really how the world works, right? Needs come up, and you can't predict it. Relationships change, you can't predict that. Emergencies happen, and we can't really predict emergencies either. So the idea would be that this interagency planning through MOUs and MOAs that have teeth that talk about who's sharing what data on what time frame and what consequences might be if we don't do that. More than just like, yep, we're working together, right? It's not just one of those MOUs, but it's a meaty one. IPAs and PCAs. So that's a primary care association or an independent provider organization. Association is another way that we can do this. IPAs are an opportunity for small organizations to band together and to act like a big organization, to credential for participation insurance together. And then we have other frameworks and structures as well that can help us to support this, including the way that we share data. We have group meetings, town halls, and things like that. And here is an overly complicated diagram that makes a lot of sense when you can actually see it. I too have old eyes, Jamie, and so even standing here, I'm like, what's that say? So yeah, there's a whole module available to explain this online from our federal partners. So now that we've had that refresher, let's get into our scenarios. So we're trying really hard to emphasize the person-centered approach to our work and our care. So we've made up some scenarios that represent people based on our experiences in working across the field, especially in Dallas, about some of the common issues that we, see and hear and experience among the people that we're trying to help. The purpose is for us to be able to gain this concrete knowledge about the dynamics and for us to understand that there's some things that we do very well and some things that we are pretty challenged with. The scenarios are designed to help us explore all of these different things related to characteristics, meanings, implications that will help us to drive our problem solving around creating a stronger medical neighborhood. And we can see from this morning, and also from working with you over the last couple of years, that you're all very much invested in this already. And so we hope that this is a good way to do this. So participants, we're going to split you up into small groups, and each of you are going to receive a scenario to read and discuss. We want you to have one note taker and one person to report back. So the breakouts will last for 25 minutes before we come all back together. So this is meant to be an in-depth conversation about this particular person's case. Just like when you're working together, you might think about other people and other cases that are similar. That is a-okay and expected, right? We learn from experience. So don't just look at what's on the page, think about other dynamics, other people, other issues that you've had that are like this and how you have worked to solve those problems beyond just, well, they need case management and I tried to send them down the hall to our case managers. Because it's actually about partnerships, right, and linkages. So obviously we can think about our strengths as an organization, but we really want you to push to think about how you can collaborate with other organizations. Ones that are funded and ones that aren't. Because the other thing about a medical neighborhood is that it's all cute that we're together here as Ryan White recipients and EHE recipients, but there are so many other hearts, hands, and minds that are touching our clients every day. Every day. So we should be thinking about those other linkages and partnerships beyond who's here in the room, who might be able to help these specific clients with their specific needs in these cases. So let's have a little example. So do you want to provide the context here?
Yes. Hi, everybody. Hi again. So the first scenario that we're going to be talking about today is about Tonya. Is a 37-year-old cis female middle school teacher and a mother of two. Tonya loves her family and is very involved in her faith community. Her church hosted a women's retreat which covered sexual health, spiritual health, and much more. Afterward, Tonya decided to get tested for STIs and HIV to empower herself. She tested positive for HIV and chlamydia. Tonya does not feel comfortable telling anyone her status. She is fearful of her children learning about her HIV and chlamydia. Let's utilize a medical neighborhood model in support of Tonya's optimal care. So the questions that we're going to be asking you in these groups are going to be, what are the resources available to address HIV and non-HIV clinical needs for Tonya here in the Dallas area? What type of relationship and information for a referral between agencies is Tonya's medical neighborhood need? And what else might be important to consider with this specific person?
So let's just kind of model that for you because we really want you to be like, hey, this isn't an opportunity to, kind of like check our phones, but really to think about these scenarios. So, Kevin, let's see. Tonya has kids. She's spiritual. This is a surprise to her. She's really nervous about her confidentiality. She really doesn't want other people knowing her business, and she's afraid for what that means for her kids. So in your experience working in Dallas, what are some of the resources that might be available to help her?
For me personally, I think the first resource I would definitely look to is obviously Dallas County. It obviously depends on where she was diagnosed and what that referral process looks like. But for her specific situation, I would probably recommend Parkland because they have more services for women than a lot of other agencies do in Dallas. It's more inclusive and has more availability. There obviously we run into issues with making sure that she's actually able to show up to all of our appointments because she does have kids. So finding an area where maybe they have daycare or have options for childcare, which to my knowledge, I'm not aware of any agencies that do provide that type of care. When it comes to, I think that's,
Here, I have a question. What if she is too nervous to use a daycare where she gets her treatment or other services because she doesn't want her kids talking to the other kids and for the cat to get out of the bag that way? I wonder if there are any opportunities for virtual support groups that we know of. Do we know of any?
To my knowledge, no, but I could be wrong. I think ASD would also be another great component because of what their program covers when it comes to women and children with the grants they receive through Ryan White. But as far as virtual, I'm not quite sure.
Yeah, so what we want you to do is to continue talking as a small group for probably about 6 or 7 minutes at least about this one question. Let's model a little bit of for the second one. So what type of relationship and information for a referral between agencies is Tonya's medical neighborhood gonna need? Like, so we already know that she's sensitive about having her information, shared. So, I mean, that might be something that we, want to say, that we probably also need to make sure that Tanya's aware that in order to receive the best quality care, there's gonna be a limited number of people that we're sharing her information with solely for the purpose of driving her care and making sure that her needs as she expressed them are met. Is there anything else that you would think is really important about the relationship or information?
Well, yes, I mean, even for me, I'm a white gay man, so I obviously can't relate to her situation. I do have children, but not really. So I don't really know her situation in like a lived experience capacity. So I think for me, if I was going through something similar as her, I would want my medical care to look like me and also understand where I'm coming from. As a woman, as a Black woman, I would want my provider to reflect that personally. And also I'd want people to understand my situation with having children and what that looks like when it comes to barriers to even attending appointments, accessing mental health counseling, and all these other resources that are there for women living with HIV.
Yeah, I think another thing that's important too is that we have our EHE friends here, and it's an opportunity for our EHE providers to listen with their hearts and minds about what might be missing, so that we can stir pots to see if we can't go ahead and get that going, to make sure that whatever we know or have a sense would be best for someone like Tonya would be accessible and not just, oh, well. Yeah, so does that help? Does anyone have any questions or concerns about this process and these breakouts? Does this seem like a fun activity? Or what do we think before we break up? So it's good?
I have a question.
Yeah, go ahead.
I literally am sitting here thinking about parts of this that I don't know. In reality, I can see this scenario. And I know you said that it depends on where she got testing. So I'm just asked this, if I go to my private doctor, my personal doctor, get testing and test positive, is that information shared with the county? And that's not coming from a negative or positive, I'm just curious, is that happen? And is communication then communicated with the patient from the doctor or from the county? Because I'm just thinking like that, back in the day, getting that call from the county is
Like out of
what
nowhere?
the-
Uh-huh.
What?
Oh my God,
Okay.
oh yeah.
So, and I'm not sure if that still is the case, like.
And it works in two levels, right? It's not just, hey, we care about you because your diagnosis, but then DIS is gonna call also and be like, so do we have a sense? And have you done other things with other people? And I think that's so right, that when, that's something that can feel also a little bit invasive, especially when someone has already expressed that they have sensitivity to their information being shared. And the historical medical mistrust, between the Black community and the medical social compact and things like that as well. So you are right on the money. And the idea wouldn't be, oh, here's a problem, we don't know, let's stop. Let's think about the implications here based on our own experiences in serving real people or in what's happened to us in our own lives. Because I can tell you, like, New York City queen here, that, I like to often remind you that no system is perfect, that like, I was exposed to like syphilis or something, in 2014, and then I got a call in 2017 asking me about who my partners were, and I laughed at them and hung up the phone, So I mean, like, these are actual legitimate issues that are everywhere issues. We can think grass is greener, but think again. Right? So in order to really think about how to make things better here, we should really be honest with ourselves about what are the things that are driving a problem, what are things that would drive a solution, and go there boldly.
You remind me of, you say back in the day, it's not that long ago, those envelopes that they used to put on your door every time you tested positive for an STI or HIV, and it's just like stapled right there because you didn't show up to your appointment or whatever. I've had a lot of friends experience that from the county years ago, but it just reminded me of that same certain situation when it comes to this woman, because she has kids and people that can open her mail and people that can go through her things, and she doesn't necessarily want that. So if that situation arises, how can we alleviate that from happening?
So we ready to break up? To get this going?
Yeah.
Oh, I knocked everything over.
Careful. Okay, so for folks who are on Zoom, we're going to set you up and you'll be able to do a breakout virtually with each other in the Zoom room. But for everybody else, we're gonna have 5 groups, and this is like all hands on deck, right? So the consultants, the staff, everybody's gonna do it. So let's just number off 1 to 5 super quickly. Do you want to start 1? Oh, okay. Thank you for letting us know. I think Joni maybe had her hand up.
Just a comment.
All right.
I was just thinking when you were talking about this female that Part D through Wiki, the Women, Infant, Children and Youth, has some really wonderful services with UT Southwestern with peer-to-peer support. They also have financial assistance to help with the children, potential daycare assistance. So there's a lot of resources through that program that specifically serve Wiki clients. So I think that that would be a great place to start with her, including people just to accompany her to appointments and things if she needed some assistance. So that's all. Sometimes they're forgotten about, but they have great resources.
Right on, Joni. Absolutely. Thank you for that shout out. So yes, the Part D with UNT would be really helpful. So Sonia will start 1, 2, 4,
5,
1, 2, 3, 4. Anthony, you 3. You're 4. Anthony, 3. 4. 4. 5.
1,
2, 3. 4, 5. 2, 3. 5. Okay, cool. Well, I thought I was gonna help hand out. Okay, cool. So we could do like 1's up here, 2's in the middle, 3's in the back, 4's up here, 5's in the back. So go ahead and go to your group. Octavia is gonna bring you your scenario. Remember, you're gonna have one person want to be a note taker and one person want to share out. We will provide the poster board here in just a sec. And then virtual people, we will communicate with you in just a moment.
Maybe where does it go? Like in the middle here as well.
Okay, so virtual friends, let's have you focus on the scenario that is on the slide. This is going to be your scenario. This is Robert. So you have your description of Robert's scenario. You have your 3 questions. We'd like you to work through. And if you can pick one person to kind of do the note taker, and then one person to report out. And just holler, raise your hand if you have any issues. We will monitor. And thank you for the thumbs up. Zoom people, I'm gonna just mute our computer here, so you all should be able to mute yourselves and so talk virtually, and just a heads up.
You guys see the case? Yes, yes.
Okay, I guess I'll go first. This says that he's on disability. I would wonder, does he have Medicare? And what benefits does he have through that? Just because he's on disability doesn't mean he has Medicare yet. 'Cause you have to be on disability 2 years.
I'd kind of like, this is Norma, I'd kind of like to get him a referral to either a social worker or some type of behavioral health person that he can talk to.
Yeah, and like HSNT, we have behavioral health. We have two that are counselors. They're LCSWs, but we also have one that's a PA that can prescribe medication. So sometimes patients will just see one or they'll see both. But then we also have, of course, case management to address any social determinants of health that are needed.
And I don't want to interrupt, but do you all have bilingual therapists?
I know in the medical centers we do, but I don't know if our LCSWs, that's a good question. Let's see.
And I don't think Dr. Pinkston and Jean are.
Okay. Is Sonia?
Sonia may, but Sonia I know. Let me double check too. But she would be the only one.
And I'm asking the question because Legacy has had a really hard time fulfilling this area, and Parkland has one Spanish-speaking therapist. And so a lot of times we'll get that referral, and we are currently doing a survey for this last quarter to see how many referrals we get that are Spanish-speaking, to see if this is a need that we really need to fulfill. We had a Spanish-speaking therapist at one point, but we were unable to retain them because we were not getting the referrals. So if y'all have them, I'd love to be able to communicate and make some referrals with you all.
Okay.
Hi, y'all. If I could just make a comment, we also have the linguistics program at AIN and can take referrals from any Ryan White funded provider to provide translation or interpretation services. So, obviously, maybe you don't want to do that for ongoing counseling, but in a pinch, if we could help her specifically with this person, to explain some things to him, in his native language would be helpful to him. So always know that you can reach out to us for that assistance, and we can come where you are to provide that service to the patient or client.
Okay, that's good to know.
And it gets billed directly through Ryan White. It doesn't cost your agency anything. It's through our Ryan White funding for our linguistics program. And we also do translation of documents as well on behalf of the agency or the client.
I just want to say, Joni, y'all are amazing. I am working with Naomi, and I am so grateful for y'all's support.
Thank you very much. I appreciate that. We're very lucky to have about 6 bilingual staff members as well. And so we're pretty fortunate to have a front desk person as well as case management and even our eligibility services. So we are very lucky in that regard. And then having the linguistics program certainly helps. So we're here for anybody. And thanks, Brooke. I appreciate that.
This is Norma. I've actually sent documents to Joni, and they're just fabulous. It was a lifesaver to have that. I think it was some type of application, and they translated it to Spanish, so that was wonderful. Just as an aside, also we have translation services that we would hook into if a client came to us. However, I'm not sure that that would be the most appropriate for behavioral health.
One of the resources we use and rely on heavily is Child Family Guidance Center. They're able to do not only therapy, but also have psychiatrists. So for our Spanish-speaking clients, that's where we are doing a lot of referrals. So just that resource is available to y'all if you need it.
And that was Child Family
Guidance Center, and they have about 3 or 4 in the DFW area.
Okay.
Hi, this is Sarah Watson from CHA Center for Health Empowerment, and we provide STI and HIV testing and clinical care services. We have bilingual staff, but we do refer out for a lot of other services. I kind of put a little summary of it in the chat. One of the things that I'm wondering if others feel would be helpful, I talked to Dallas County about this, is putting together a document that all of the groups have access to that lists not only what our organization name and contacts and numbers and email addresses are, but also summarizes the services that we provide. At CHE, we're working on updating our referral list for our providers, and something like that would be so helpful to us because we all have the same goal to end, the HIV.
Hi there.
And
Sorry. Hi, this is Kevin. I'm hearing this conversation and I'm curious. You said you talked to Dallas County about putting together a potentially like a list of all the recipients and the services that you all
yes,
provide.
well, they did do an initial one that had the names of the organizations and the contacts, but what was missing was what services do they provide, so that I could look at them without calling every one of them and say, do you do this? Do you do this? Do you do that? Just to have a summary of what services each provider offers, so I know what's a ready resource and you can cut down on those phone calls or emails.
Findhelp.org is an amazing resource for all of that.
Joni, get out of my head.
Great minds think alike, Kevin.
What was that?
It's called findhelp.org. It used to be known as Aunt Bertha, I believe, but it is a wonderful resource. And you can find virtually anything Ryan White, non-Ryan White, clothing, housing, any need. You basically type in the need and it will give you every resource. You can type in a zip code. It is an amazing resource and you can directly connect. You can even refer. It is wonderful. And they will come out and do presentations to help you get your information in there, help you get your information updated. And it doesn't cost you anything to be part of it. But it has largely taken place of what used to be the handbook that Parkland used to issue that hasn't been issued in a couple of years.
Hey, Cheryl, this is Kevin too. I know Center for Health Empowerment is actually on findhelp.org as well. So maybe I would reach out to Scott and see if there's like maybe you could access it, because CHE can receive referrals directly through findhelp.org. So I would maybe reach out to your leadership and see what that looks like. And then also, since you are an EHE subrecipient, EHE has a direct contract with findhelp.org. And so maybe you could speak to Miranda about maybe their processes and things. And then also, I really love the idea of putting together like a little EHE Ryan White resource guide so that you're able to reach out to people. So I'll talk to my internal teams here and see what we can do to put that together for you, or for everybody, but yes.
Hey, Kevin, also over the next several months, John Dornheim has scheduled many of the agencies. He's reached out to each subrecipient that's funded, I believe, and is having them present at Ryan White. I realize it's a verbal presentation, but wanted to mention that as well to learn more about each subrecipient.
Thank you, Joni.
Kevin, this is Norma. As was spoken earlier, we used to have a handbook that came out that was funded from Dallas County and was awarded to agencies. It used to be Resource Center, and then Parkland took it over, and I think then it stopped. Is that something we can get started again? Because that handbook was not only in English, but was in Spanish and was given to new clients. So my question is, can we do that again?
Hey, Norma, this is Kevin. I'm thinking so. I don't see like what the issue would be as to why we couldn't. So I'll talk to Oscar and I'll talk to Sonia and see what we can do to collaborate internally to make that document come to fruition for you all.
Yeah, I mean, I know it may be a funding issue, but I don't know whether EHE funding could potentially be used for that if there isn't any Ryan White funding available. There's a lot of printing costs available.
Yes. Yes, and yeah, I can talk internally about that, and you know, EHE funding is a little bit more flexible when it comes to those things, so we can figure all that stuff out internally and make sure that
They give us
each
a
subrecipient is able.
3-minute
Yeah,
countdown.
it
We
was
got a
absolutely
3-minute
wonderful.
countdown.
English and
Absolutely, Papa.
Spanish, then you could just hand it to somebody.
Absolutely. I think we're about to go into the report outs, and then we're going to close out the meeting. So I am going to put myself back on mute, and we'll look forward to hearing what you share out.
We got 1 more minute. 1 more minute.
What they already know, have they already been in the community, you know, those type of things. And like you're saying, somebody who said about it, that's
And by the way, if you don't have a chance to go downstairs,
but you have longer arms. Yeah.
Yeah, oh my God.
Okay, if you can hear me, snap your fingers. You can hear me, snap your fingers. Awesome. Okay, we want to welcome back our virtual fam and our in-person. All right. So we can go ahead, let's wrap down those conversations. Welcome, other friends who are joining for the afternoon. Okay, so I want to say thank you to everybody. I'm really encouraged by the dialogue we heard. And I see we have awesome note takers and report outs. So very quickly, we can just hear maybe 1 or 2 key kind of takeaways. Again, Michael challenged us to think about what are the things that facilitate really good connection of resource and medical neighborhood in Dallas, what your scenarios, and maybe what are the things that we recognize are gaps or challenges, right? We can look at both of them equally in this space. So I'll just kind of like go around, but just 1 to 2 key kind of takeaways from your team. Let's hear some report outs. So I think this is my group 4. Who's my speaker? Not here else. Okay, here, go ahead. Okay, thank you, Fred.
Since Robert, which was his male, knowledge of HIV was based on people who kind of passed away in the past. He may need current HIV information to understand if there's effective treatment now. The scenario didn't really mention his sexual orientation or immediate support system, so these things should be explored further as referral is considered. Spanish language services seem to be available for a lot of services that were mentioned. We talked about North Texas Behavioral Health, ADAP, Parkland, Prism, Ryan White providers, HAPA, Ryan White advocacy groups, Another really important point was that Texas is a dual reporting state. So not only the hospital will know his status, but also county, DIS will come to the door to ask questions. And that we want to make sure that Robert knows this prior to that visit. And it would be really important to respond to calls initially to prevent any kind of surprise visit. We also talked about like Texas Workforce Solutions, things like that. The notes sent to do not. Oh, the notes sent do not state the status of the potential client. And so that should be kind of clarified if that note won't actually state the status with this, that they need to contact the health department.
I appreciate that. We realize there's some space for clarification, right? Like, what does the note say? Also, let's have we explored, because again, we see Robert's scenario on the screen, right? So things like sexual orientation, other pieces, there's still some discovery. There's still a lot we want to get to know about Robert. Let's hear from, I may have to ask you for a 5 or 1. I'm going to ask you to use the mic so people can hear you. Do you mind if I come forward? So Brandon's going to represent our 5s. Who represents our, I'm sorry, our 2s? Who's our 2? Come on up, friend. Come on down. I'm living the Bob Barker dream. Fun fact, we're from the same hometown. Oh.
Are you?
Yeah.
In group 5, a number of our folks stepped out, so it's just the 2 of us in here. So our scenario was Christine, who is a 22-year-old trans woman. The biggest thing to note is that she tested positive yesterday with an at-home kit. And that kind of formulated the conversation because some of these things are assuming that she reached out. And so before we get to that, it's where did she get her kit? Did they include information on how to contact them? And these are things that I didn't know. I literally was over there getting a whole education because I was like, well, what about this scenario? What about this? And learning these things from the group. And then Corey came in from Abounding Prosperity and just took it to the next level of, okay, so we need to find out what is important to her. Like, she's gotten this at-home test. When she reaches out, then that organization then building a relationship with her to get her, 1, accepting of where she is with her status, 2, finding out what are the things that are truly the most important to her. Does she want to get this name change done? And then Corey laid out how they would start the process of getting her linked to care, and over that first visit, then they have the second visit in the 60 days, building that relationship, and they would be working on the name change at the same time while they're going through this, which then builds trust with the organization and her so that she can continue on the momentum. Then we talked about what are the additional resources that are available based on her needs assessment. What is it that is important to Christine so that we're looking at the entirety of it. So now some of the other things that I didn't know, I'm gonna be honest, I was a little green on something. I didn't know you could get an HIV self-test at Walmart. Literally just found that out 10 minutes ago. And so then because they were sharing at AHF that they provide an information sheet so that if you do test positive, that you can reach out to AHF. But I was like, okay, at Walmart, what do they get if they test positive? Like, who do they reach out to? And she was sharing, my colleague with Legal Hospice, that that people Google search. You know, there are a number of different things that people are going to look for. I tested positive, or, you know, now what, or different things. And then that leads people to the different agencies once they're Googling, or if they go to hiv.org and then fill in their information, it's going to connect to different agencies in the area. And so, yeah, it was very informative for me to go through this exercise. But I think back to us, it was really what does Christine want to do and how does she reach out after taking this at-home kiss? Because there's nothing that's immediate or automatic with it at that point in time.
Yeah, we can hear from our other groups. We have our 2s coming up. All right, and we have Chauncey, yes? Yes, we got Chauncey. This is scenario number 3. So first of all, good morning, everyone. So the Chauncey would what stood out for us is that he had been on PrEP for 2.5 years. However, he lost his medication, after his mother lost his insurance. So, that's the insurance that, was covering Chauncey's PrEP medication. And after, testing positive at an HIV, weekend outreach event, we thought that, similar to what the previous group said, is that we really want to know who Chauncey is and what his needs are. So, when it comes to, the first question, we thought it's better to give him a list of options, depending on what, his situation is. So is he interested in receiving, LGBTQ, services? Does he have issues with transportation? Clearly, more than likely, he's gonna need, medication assistance, so we wanna make sure that we refer them to a provider that can assist him with that. For question number 2, when it comes to what kind of information, agencies should exchange, something I just learned about is Z codes. Is anybody familiar with Z codes? I was not, I just learned it like 5 minutes ago. So Z codes basically assess like the social determinants of that, of a person. So it's a code that basically says whether or not a person could be in, experiencing, poverty, maybe mental health or things like that. So as I like to say, it's like public health really does deal with, individuals in a holistic manner. So assessing all types of, barriers and all things, that a person might be experiencing, is important. They're not just, an individual with a list of signs and symptoms, they're a person. So we want to make sure that we address everything, so that we can facilitate that care for them. Also for question number 2, we thought it was important to share, mental health screeners. So maybe, I forgot the name. What was it? The PH? Yes, PHQ-9, which, I know not all clinics offer. It's usually for clinics that spend a little bit more time with individuals, but it is important, to hear that, because we all know that, sometimes this kind of news can take a toll on people. So assessing their mental health stability is very, very important. And we did not get to question number 3, but, I think, support groups are important. I'm actually from El Paso, Texas, and we have this program called Empowerment. And they have a great support group for, people living with HIV or anybody from the LGBTQ community, and they have fun activities that, they can do for them. So they get to go to the movies for free. They get to go to Topgolf for free. So I think it's very important that we give them the opportunity to socialize with individuals that might be experiencing the same thing. And that is it.
Hi. Group 3, we had scenario number 2, Robert, as well. I'm not a strong public speaker, so please look past my insecurity.
Yes, you are, baby.
So for us, at least personally, I think like in a timeline sense, number 2 would probably be what we would look at first. We talked about the possibility of, since he was hospitalized, maybe during hospitalization being referred to a clinical health worker, who is bilingual. Obviously, if he prefers to speak in Spanish, and is best expressing himself that way, we want to, follow that. Maybe upon release from the hospital, making sure he gets connected with a non-medical case manager. I think especially for people as a, case manager myself, having that support, especially upon a new diagnosis, it's really important because the kind of program is very overwhelming at first for a lot of folks. So maybe getting them connected with a non-medical case manager who can connect him to behavioral health resources, maybe social health resources, we have a lot of, options. He is disabled, so we assume he's low income. So we want to get him connected to a resource that's funded. So maybe Legacy Cares or Bounding Prosperity, where they do offer Spanish speaking therapy. We also considered that since he is an older gentleman, getting him connected maybe with a support group for older folks that is Latinx focused. Maybe also, it's mentioned something about veteran services, but I don't want to make assumptions, but we do consider that too, about making contact with a VA caseworker for the possibility of that as well. And really, because he is low income, there are a lot of things to consider. Maybe getting him connected with food resources. He has vision loss and a left eye, so maybe considering transportation resources as well. And also looking at FMLA consideration of these employees. So.
Okay, thank you. Great job, great job, great job. We're gonna come to our virtual group here too as well. We're getting ready to wind down this morning's session. I do want to thank you for a little bit of extra time. We may notice some folks who are registered for the afternoon session are joining us, so welcome. We're just doing some kind of case conferencing. So we're going to be wrapped up here pretty soon. Actually, if we want to just, we can take down the share screen and we can just hear from, if we have folks in the virtual room who've been able to hang on a little bit, if you all want to share. Anything that's not been added from what we've heard of for your pieces. You have to unmute yourself. Or drop it in the chat. We'll touch back. We'll touch back. Kevin, if you want to go ahead and put up the evaluation poll. So just a couple of quick reminders for our Ryan White and EHE funded family. Your next quarterly QI submission is going to be September 15th. So that will be in glass cubes. And again, we just continue on that quarterly basis. We're going to be having our World AIDS Day event in December as well. We have a quick evaluation poll that folks can either hold up their phone with the QR code. We'll also drop a link in the chat that we would like you to help us assess today, this session. So we'll give you a moment to do that poll. Give yourselves a round of applause. And then I don't know, Miranda, if you want to explain what's going to happen in the back, and then Kevin and I will be telling you one more quick thing. Hello, welcome everyone for joining us. Some folks are staying all day. If you're just coming in, we had a quality improvement webinar for funded Ryan White and EHE subrecipients. So that's what we're wrapping up right now. If you are staying for this afternoon, please feel free to go out this door after you've done the evaluation and heard from Kevin. And then we do have some lunch for you all. And at around noon, 20 minutes or so, we'll go ahead and get started with the presentation. Thank you for coming, and we appreciate you, but here first, listen to Kevin.
Hi, everybody. Is everybody still awake? Thank you all so much for attending today. We really appreciate the time that it took you all to get here and spend with us. So thank you again. If you do have some free time, this is not required, it is optional, but we are going to do an aim statement treasure hunt. So out of all of our 12 subrecipients, we have laid out every single one of their aim statements outside in this hallway on the left. There are some little sticky notes that you can attach to the wall, depending on how you feel about the aim statement. So the first is going to be an intervention or change idea to bring back to your agency and potentially replicate. A star sticky note will mean meaningful engagement of cross-sectoral teams. A square will highlight or high five for something interesting, novel, or a shout out. And the word bubble will pose a question for the team regarding their aim statement. So whenever you have a free second, please exit out this door, go get your food. That door. Go get something to eat and feel free to engage with the aim statements. Thank you all so much.
So it's like a lunch break until what time? Noon.
12:30.
12:30.
That's
No,
what-
1:30?
That time is.
That time.
Sorry, 12:30. That's my computer, sorry.
Yeah, so we have the lunch hours from 11:30 to 12:30, and at 12:30 we'll begin the rapid start institute. Thank you all.
Good job.
I can go back. You definitely should. Yeah, sure.
Is honestly, there's gonna be other opportunities, but it would be helpful because we're getting pushed around the stuff. What is, gather. It's not that it's new, but we're trying to get it widespread around now. This is gonna be more clinical focused, it's gonna be more implementation, kind of focused, that kind of thing. But, so.
I see it.
So, I mean.